Hello, everyone. Welcome to another episode of Ultrasound Podcast. This is Dr. DrBarai. I'm a consultant in emergency medicine in Victoria, Australia. In this episode, we have got a very special guest today. He is none other than Professor Eugenio Picano. He is joining us all the way from Pisa, Italy. Professor Picano has an illustrious career as a cardiologist for over 40 years of clinical experience. He has a significant contribution both on the clinical fields and in academic aspects in lung ultrasound. It will be a great privilege welcoming Professor Picano to this podcast. Without further delay, please join me in welcoming the very special Professor Eugenio Picano from Italy. Thanks, Professor Picano, for joining us. It's a great privilege having you here.
Thank you, Avid. It's my pleasure to join this very interesting podcast. Thank you for having me.
Excellent. So, lung ultrasound, that is such an important topic from my perspective in the emergency department. We use this all the time. And I'll be very interested to know, and my audience will be interested to know, from a cardiology point of view, what is your take on this important topic? So, Professor Picano, tell us a little bit more about it. When did lung ultrasound enter cardiology, and how you have become interested in this interesting topic?
Well, to give you an idea of how attractive is the world of lung water for a cardiologist, I will tell you that when I was a medical student in Pisa, at that time, we were very lucky to have one of the giants of contemporary cardiology, being the chief of the coronary care unit team. It was a Professor Attilio Maseri, who later became the cardiologist of the Queen in England. He headed the Hammersmith cardiology division, and then again the personal cardiologist of the Pope, since he was appointed the chief of cardiology in Cattolica University in Rome. He was a giant, and we had Attilio Maseri at his prime in the late 70s in Pisa. And one of the major target of his clinical research is considered the father of coronary vasospasm, but he also had many other interests. But at that time, there was a very sharp focus on extravascular lung water. At that time, we had a professor of pneumology, Carlo Giuntini, who was very active in the field of extravascular lung water. And as a matter of fact, they made very important internationally acknowledged contributions, but we understood very well as their students that the target was very important for a cardiologist to have a reliable biomarker of pulmonary congestion, but they fell short of it. In spite of using a very advanced technique, they used the chest X-ray and built a semi-quantitative chest X-ray score based on Kerley-B lines, HeLa, congestion and density and other parameters, but chest X-ray was not early sensitive enough, was not enough quantitative, was highly operator dependent, required a radiology apparatus. Then they went on with nuclear medicine techniques based on double tracer indicator dilution technique, one tracer for intravascular compartment and one tracer for all the water, diffusible tracer, and with the very complex calculations using radioisotopes with all the restraints of nuclear medicine. They had a score for extravascular lung water, but that didn't work clinically, practically. And they obviously went to the gold standard of invasive assessment, but of course you need lung water for every patient, not for those in intensive care unit with catheters in. So for my personal history, This was the cultural receptor for understanding the importance of extravascular lung water. 30 years after, when I was running as the head of the cardiovascular ultrasound lab in the Institute of Clinical Physiology, the laboratory, I read by chance the article in 1997 of Professor Daniel Lichtenstein, who is considered, and rightfully so, the father of lung ultrasound. He is an intensivist. So obviously his research was focused on intensive care unit, but this was pure gold for us because it was really the road to extravascular lung water. So at that time, we had fellows from all over the world, and there was a bright Hungarian fellow that was dedicated totally to assessing, evaluating, and refining the technique in all patients in our hospital, in patients in the cardiology coronary care unit, in the pneumology ward, because we had also the pneumology ward, and outpatients. All of them made systematically ultrasound for B-lines, and this led us in 2 years during the fellowship of our bright Hungarian colleague, Dr. now Professor Zoltán Jambrik from Szeged, Hungary, to really understand the potential of the technique. And in fact, in 2004, the first paper on lung ultrasound for lung water in cardiology was published on the American Journal of Cardiology. So we had the cultural receptor. Then 30 years after, we had the tool, and it was easy to combine the pathophysiological potential with the technological instrument, and immediately we understood that we had a very powerful tool to identify, quantify, follow up lung water. And after 40 years, the old dream of Professor Masari and Professor Giuntini came true in our hands. Basically, it was not necessary to have catheters, to have complex nuclear medicine techniques. It was not necessary to have chest X-ray with a very composite, complicated chest X-ray radiological score. It was enough to move of 2 centimeters the ultrasound transducer from the apical window to the third intercostal space, and to have a view on the underwater world of pulmonary congestion.
Excellent. So this is this can be done at the bedside, and this can be done. It's a non-invasive process. It's such a powerful technique. So why is the lung ultrasound important in cardiology, Eugenio?
Well, first of all, you have to know that now in the core curriculum of every cardiologist everywhere in the world, and in the office of every cardiologist, even with a pocket size or iPhone, smartphone instrument, you have access to ultrasound. So it's something that you can do since decades everywhere, in every patient, and by virtually every cardiologist. And you cannot become a cardiologist if you are not familiar with echocardiography, at least the basic world of left ventricular volumes, function, ejection fraction, and so on. So you have already the culture, and you have already the tool. You have just to expand. So you have to consider that while the lung ultrasound can be a demanding technique when you use it for all the impressive spectrum of application in an intensive care unit, basically for cardiologists this is much simpler, because we have two main targets that are really the elementary school. I would suggest the kindergarten of echocardiography. One is pleural effusion. We know pleural effusion since decades because patients, for instance, with cardiac surgery, the main tool to identify pleural effusion, that is a very frequent complication to follow up, is bedside ultrasound. We know this since 40 years. And now, if we go to just above the usual or around the usual cardiac acoustic windows, we see water, focusing on B lines. And B lines are really in the paraphernalia of lung ultrasound are maybe the simplest sign, because we have schematically the normal black lung, which is a dry lung, the black and white lung, that is a wet lung, and the total white lung, that is a severe pulmonary edema. So with these parameters in our hands, it's difficult to miss the diagnosis of lung water, and it takes very few minutes, I would say very few seconds, to screen the patient. Once you have him or her on your bed, and you make the ultrasound scan, you just add the 1 minute scan for B lines, and you have an information that is the old dream of the cardiologist, because starting from the neck, we learned that you have to make the physical examination, listening to the heart sounds and listening to the lungs. And basically, this is the same thing. You ultrasound your heart and you ultrasound your lung with the assessment of pleural effusion in some patients, or in all patients, B lines.
Excellent. Thanks for that updates. So how many laboratories use the lung ultrasound in every cardiological practice from your experience?
Well, I will not tell you my experience, but the largest experience of one of the most active echo communities in the world, which is the Italian community. We were lucky enough to have a lot of pioneers in the field, and both from the clinical and the scientific standpoint, the Italian community is very advanced. We are lucky enough to have the results available and published of a survey of the Italian Society of Cardiovascular, of Echocardiography and Cardiovascular Imaging. And they made this survey, including the probing of lung ultrasound activity in every lab. We have in the society about 3,500 cardiologists. So it's the largest imaging society in Italy and in Europe. And the data were very interesting. You have to consider that in Italy, we worked, obviously, it was easier to disseminate the technique in our country starting 2004. Then we published intensively until now, and a lot of different groups joined also in multi-center research projects. So this made the penetration easier. But the snapshot of the acceptance of lung ultrasound gave these results, that before COVID, 2019, we had a 50% acceptance rate and current use of lung ultrasound in Italian laboratories. After COVID, basically cardiologists had to take care of COVID in the emergency room. And therefore, those who didn't know it immediately tried to learn. There were also tutorials and intensive exchange of information and dedicated teaching courses by the society to teach those who were still outside the lung ultrasound game to join in a hurry because patients were coming. It was, as you know, a real tsunami, and the cardiologists were in the front line trying to deal with these patients. And immediately it appeared that lung water is lung water. It can be sterile, as it happens with cardiogenic pulmonary edema, or can be dirty, infected, as it happens with COVID. But the basic signs were really the same. And this determined our cardiologists touched with their hands and saw with their eyes how important is this tool, this sign. And to make this long story short, when they repeated the survey in 2023, the acceptance rate of lung ultrasound was 95% in Italian laboratories. So basically, no lung ultrasound, no party. I have also to tell you one thing that made things much easier, and we may be biased on this since we made this technique refinement, but I think it's a wise move that laboratories increased their acceptance rate dramatically, also with the simplification of the technique. Because when you and we used it until 2017 in research clinical, but when you have to do 28 site scan as it was originally suggested, 3 minutes are too much for a busy echo lab. The workflow is slowed, and this is unacceptable. So when we introduced, we will talk of this later if you wish, but it was important also during stress. And during stress, you have so many things to see, and things are changing rapidly. You cannot take 3 minutes to make a scan at rest and a scan during stress. So it may seem strange, but 3 minutes were too many for a busy cardiologist. And so we made a methodology study with 3 centers around the world in a very short time. We basically scanned in every patient 28, and then we evaluated the sensitivity of the technique, comparing 28, 16, 8, 4, 2, 1 sites. And we saw the obvious, what we probably already knew, that not all sites are created equal. There are some wet spots where the water is easily detectable, and so if you make the 4-site scan, you have basically the same information that if you make, at least in the heart patient, in the cardiology patient, you have the same information. And this is a little bit the same thing that happens with ECG. You can make the ECG map with 100 leads. You can make the 12 lead ECG, and with the Holter, you can make one ECG lead that is very close to the third intercostal space, that is also the hot spot for water, or maybe we should call it the wet spot where water preferentially is detected, and you do not lose so much information with the Holter monitoring with 2 leads. With the lung water, we use 4 sites, and with 4 sites, the acceptance of the network that includes for stress echo 2030, 50 centers around 20 countries all around the world, including USA, China. The acceptance immediately rose, and now virtually all centers do stress echo. So 4 free, 4 sites, 3 on the left, uh, four sides, third intercostal space, two sides on the left, two sides on the right. And in this way, it's much easier to have information without losing too much time, because cardiologists and especially stress echocardiographers are obsessed with time pressure.
Exactly. So that brings to the next question, that what are the technicalities? How do you do it in cardiology?
As I told you, now it's recommended also by the recent European ESCVI guidelines, the four-site simplified scan. On this, we are gathering data. We have already data on the prognostic impact, and we scan basically the third intercostal space. This is the wet zone for us, and we start from the mid axillary to anterior axillary, from anterior axillary to mid clavicular on the left and on the right. We do this symmetrically, and in less than 1 minute you have the scan. From each, we have also, as we know, it's not only a yes or no or binary diagnosis. You can quantify, and this is very important because, of course, the more the water and the stricter the indication to therapeutic intervention, and the worse is the prognosis. So we need to quantify. The quantification is very simple, because for each site we have a score from 0 black lung to 10 white lung. In the mean, we count the individual B lines. We add up the four sides, so we have a composite score from 0 dry lung to 40 pulmonary edema. And this we count, we record, and it is an ideal tool also to follow up the patients in natural history or after therapeutic interventions such as diuretics or dialysis.
And when you say scoring 0 to 1 in each of those four areas,
0 to 10, sorry.
0 to 10, sorry.
So the overall score is 0 to 40, because each site is 0 black to 10 white.
Is it the number of the B lines you are talking about, or this is just the visual appearance of the lung field?
No, it's well, this is a good point, because some make and some automatic tools now make the integration of the white over black, the area. But until now, we found it easier to count the individual B lines.
Excellent. Yeah. And what I understand that in these four zones, you are not looking at the dependent part of the lung, which is at the back.
No, that might be useful for detecting, for instance, pleural effusion. But
Yes.
for B lines, we stick on this, because after mapping all the sites, this came out pragmatically as the most informative. And at that point, you apply the Occam razor, ensia multiplicanda non sunt sine necessitate. We go on the simpler, straightforward way without adding something not strictly needed.
And when you say you do the mid-axillary or anterior axillary line, what intercostal space you do that? Is it still in third?
Third, all third. No. Third intercostal space. This is the hot zone. As I told you, 4, 3, 3. So 4 simplified four-site scan.
Yes.
And the third intercostal space on the left, we start basically from the right, and the third intercostal space on the right.
Right. Thank you for the explanation. So obviously, it's a very simplified process and very informative as well. But like many other medical assessment or investigation processes, it must have some challenges or difficulties. So what are the technical difficulties that you encounter or you are aware of in learning, acquiring, and analyzing the B lines for a cardiologist during performing the lung ultrasound?
Well, of course, as all things in cardiology or in echocardiography, the technique does not tolerate improvisation. And you have to undergo a learning curve, a teaching module. I have to tell you that for both research and clinical purposes, we have developed a 2-hour web-based learning modules, and apparently this is all you need because we tested the inter and intra-observer reproducibility of various parameters, and those with the highest reproducibility after a standardized teaching web-based course on lung ultrasound naive colleagues. The results are very encouraging. Basically, this is much simpler to teach and to learn than other aspects of echocardiography. And this is also witnessed by the fact that if you go through the recent literature, now basically this is something that the trained nurse can do, and even the trained patient. Now there is a great diffusion, especially in chronic heart failure patients, of since also some hospitals supply the technology, some affluent patients can afford it. They do it by themselves.
Wow.
And they send you the images, or they interpret the images, send it for confirmation. But after a while, there are data in the literature, they learn how to do it. And basically, it's like blood glucose. You don't need the endocrinologist to say that 150 or 2000 or 200 is too much and 60 is too little. So they basically use it and can titrate the drug use by themselves.
Excellent. So that's a really interesting challenge, but at the same time, it can be addressed so well with the new development of technologies. So, as a cardiologist, you are using it, the lung ultrasound. What are the other areas of scope of practice? I noticed that you have got quite a few papers where you have demonstrated the use of this in pediatrics, for example.
Well, in pediatrics is very important because we have the problem of protection of our children from the toxic long-term effects of ionizing radiation. So the standard is chest X-ray or even CT, but in this way you spare a lot of chest X-rays and ionizing radiation. As we know, there is a growing concern for medical radiation as an important cause of cancer. This is true in all patients at all ages of life, but it is especially true for women that have a 38% higher cancer risk for any given physical dose of X-rays, and in children. In children under 1 year, you have 4 times higher risk of developing cancer. Now we have not only theoretical data from epidemiological evidence from atomic bomb survivors or from nuclear power plant workers. We have direct, convincing, heavy evidence on the medical populations of children. We have the EPCT study just out and other evidences so on cancer and non-cancer, including atherosclerosis effect of ionizing radiation. So every effort should be done to minimize the radiation exposure in these patients, and the paradigmatic example is pneumonia in children, where lung ultrasound can be very useful for the initial diagnosis and obviously for the follow-up. You spare a lot of radiation with patients. So we were lucky enough to have this Dr. Caiulo, smart cardiologist in a very small hospital of South Italy, and they identified this issue many years ago, more than 10 years ago, and now the technique application is recognized in pediatric guidelines. This is one application, but there are much more in virtually all fields of medicine. If you stay again on wet B-lines, it is very important, for instance, in extreme physiology, because you have B-lines when you go in apnea underwater, you have B-lines, and this is a potentially life-threatening risk. There are also some devices for monitoring underwater with ultrasound the lung. It has been found in marathon runners and very important in high altitude trekkers. You have an intermediate phase of acute mountain sickness where you have B-lines, you don't have symptoms, you keep on ascending and you develop full-blown life-threatening pulmonary edema. So it's extremely important. We did this study with our colleagues, Francesca Frassi for the apnea study, and Lorenza Pratali, who is a cardiologist, but also an active trekker. And they found this when they went in Tibet and in trekkers of their community. And it is important that you can do it with portable echo. So it's very important in this setting. It's also extremely important in nephrology, because thanks to the work of Carmine Zoccali, who is a leading nephrologist in Reggio Calabria, South Italy, they made a study, a $1 million study funded by the American Nephrological Society, and was the first randomized study. They showed that if you have a dialysis titrated with lung ultrasound rather than with the weight changes, you have much less episodes of hypotension and other important side effects. Now, there are other studies confirming this information in nephrology. And then there is another very important application, rapidly accepted. We did this for the first time in 2008 in Pisa with our rheumatology colleagues. And then this has been accepted because together with wet B-lines, there are dry B-lines made of connective tissue. And this is a very important sign in rheumatologic disease, for instance, systemic sclerosis. The same sensitivity and the same prognostic value as CT. And obviously this is very important because in rheumatology they have two major prognostic vulnerabilities. One is pulmonary fibrosis, and we can see with lung ultrasound. The second is pulmonary hypertension, and we can see with echocardiography at rest and during stress. So really you have, with the addition of lung ultrasound to standard echocardiography and possibly stress echocardiography, a one-stop shop for functional anatomic testing that explores all the vulnerabilities of the cardiac and non-cardiac patient.
And excellent. Thank you for sharing that. So Eugenio, when you say that echocardiography and lung ultrasound, do you change the probe or do you use the same phased array probe for the lung ultrasound, just like echocardiography?
We are very well aware, and Professor Lichtenstein taught us beautifully that you have a better resolution of the pleural line and you see better with higher frequency. But let's say this, that there is the principle of minimum energy for the busy cardiologist, and we de facto do it with the cardiac transducer. And we saw them reasonably well. If we count to 3 instead of 4, doesn't change anything. If there is a prognostic impact, if you are in doubt, in our opinion, it means that it's not so clinically important, and therefore, to spare time, even when there is the 5 megahertz transducer there, I have to tell you the truth, cardiologists go with the cardiac probe.
Right. Okay. Yeah. Excellent. So you mentioned something about the stress echocardiography. So tell me a little bit more on the use of lung ultrasound in stress echocardiography, Eugenio.
Well, this is a part of what was a radical reshaping of functional stress testing in the last 10 years in cardiology. If you think of it, as cardiologists, we for 40 years, and we were the first to do this, focused on regional wall motion as a marker of epicardial coronary artery stenosis. But now, as cardiologists, we know very well that coronary artery stenosis is not the only, and probably also not the most important factor of vulnerability for the cardiac patient with chronic coronary syndrome, so with heart failure, or with hypertrophic cardiomyopathy, or whatever. So we know from our masters that we have many different vulnerabilities, and certainly pulmonary congestion that in somewhat mirrors diastolic function, because you have an increase in left ventricular filling pressure, increase in pulmonary wedge pressure, you have lung water. And up to now, the echo tools for assessing diastolic function were suboptimal, difficult reproducibility, very difficult during high heart rate condition. Instead, with lung ultrasound, we can have this information in everyone, and therefore the new up-to-date protocol for functional testing is ABCDE, where A is for asynergy, regional wall motion abnormality. B is for B lines by lung ultrasound. C is for volumetric echocardiography, because from systolic volumes we have information on contractility, and from diastolic volume, left ventricular and diastolic volume, we have information on preload reserve. D, because with Doppler we measure on the left anterior descending the coronary artery flow velocity, which is very important because microvascular coronary dysfunction is a hallmark of disease in very different conditions within and outside the coronary artery disease. And with EKG, we have heart rate reserve. So B lines are a part of the standard protocol, and they are very important because we saw that it is an incremental prognostic information even when you consider only all-cause death as your endpoint. So yes, it is part of the standard protocol, and if you think of it, it's very reasonable because when you test the consecutive population, for instance, in heart failure, you have 1 out of 3 patients with B lines. You make your stress physical or pharmacological, because also pharmacological stress, vasodilators or dobutamine are a strong diastolic stress, and instead of 1 out of 3, you have 2 out of 3 patients who have B lines. So you unmask a condition of latent diastolic dysfunction and pulmonary congestion. Why is this important? Obviously, it's important in the same way as you make an ECG and ECG is normal at rest, you make the stress and ECG is abnormal. The patient in his or her daily life exercises or is stressed in several different ways. So what you see during stress is even more valuable than what you see in the natural condition of rest. So it's an adjunct of functional testing, and the underlying concept is that the good cardiologist diagnoses and treats the coronary artery stenosis, but the best cardiologist assesses the patient vulnerability and risk, and that's to go beyond the stenosis.
Excellent. Thanks for that. With regards to the imaging lung water in cardiology, how does this lung ultrasound supplanted other imaging techniques?
There was recently a review paper published on JACC imaging, and they showed that different techniques that were used in the last 50 years for imaging lung water in PubMed search, they were all with a flat line from 1980 to now. But then echo lung ultrasound came, and all of a sudden, the first paper is in 2004, which is our paper in the American Journal of Cardiology, and it skyrocketed, and now there are hundreds of patients or papers every year. Now, PubMed is not important. It's important that it is a mirror of the penetration and dissemination of the technique everywhere. And this will be more and more true in the in next years. Why? Because you have to consider the days that we only evaluated the accuracy of the technique for lung water, for myocardial ischemia, for left ventricular function. These times are over. It's the old way of practicing medicine, because we have to include not only the accuracy, which is something that the physician considers, and many guidelines still evaluate only the one dimension of accuracy. In the present era, this is unacceptable, because we have to consider the sustainability. Sustainability has three pillars, the triple bottom line. One is economic. You cannot buy information with $2,000 if you can buy it with $100, because you have to consider the value. This is obvious in all sectors of economy, but in healthcare, this is ignored. Then you have to consider radiologic cost. How many equivalent of chest X-rays? If you have more or less the same information with a non-ionizing technique, you cannot, in Europe by law, you cannot use a ionizing testing technique. And even if you gain 2% or 3% or 5% of accuracy, this is nothing compared to the risk that you give to the patient. So you have to consider economic sustainability, you have to consider radiologic sustainability, and now we have to consider environmental sustainability, because we are in a climate emergency. Now we have no money for healthcare. We have an increase of cancer with a large share that is estimated about 5 to 10% for medical radiation, excluding radiotherapy. We have climate emergency, and medical imaging accounts for 1% of the total carbon dioxide emissions of the planet. So we must solve the problem, but we are also a part of it. And therefore, if you compare the different techniques, you have lung ultrasound costs 1/10 of a CT, maybe 20 times less than a CMR, and certainly 100 times less than an invasive catheterization. For radiologic cost, you have 0 chest X-rays for lung ultrasound, 0 chest X-rays for cardiovascular magnetic resonance, and you have 200 chest rays or 400 for a CT, and much more obviously for other techniques now, basically out of the market, such as the nuclear medicine, positive emission tomography, that costs 100 times more than an ultrasound, or SPECT scintigraphy. They have also been proposed and used, but now virtually disappearing from the clinical arena for these reasons, that you have to consider everything. The carbon dioxide emissions are 30 times higher for a CMR compared to a lung ultrasound. 10 or 20 times higher carbon dioxide emissions for a CT, and 100 times for an invasive procedure. So, for these reasons, now lung ultrasound is the dominant technique, and it will be increasingly difficult to use other techniques for clinical or research purposes, because we have to consider the sustainability index, which is accuracy. Physician evaluates accuracy. But in the denominator, there is economic cost. The payer evaluates this. The radiologic cost, and the patient must be informed of the long-term risk, and the planet, the carbon dioxide emissions. So our generation was allowed to ignore completely 40 years ago every kind of this comprehensive evaluation, because we thought that the more exams we did, the better doctors we were, and the better the patients were treated. This is completely wrong. We have to include the triple bottom line. If you do this, and you must do this by law, now even in the Ethical Code 2022, there is that we have to consider the environmental consequences of our medical acts. If you do this, you have to start with ultrasound, and then if there is a dark area in your diagnostic workup, if there is a missing critical information, you can go on to other testing.
Excellent. Thank you for sharing that. Now, what is the future, where we are heading to? So as you have mentioned, that over the last 40 years, you have seen how the ultrasound has evolved in cardiology, and especially the lung ultrasound. From in 2024, what you envision, where we are heading to?
Well, there are two pathways that are already very clear at the horizon, and they are the future, but they are also the present. One is to make the examination totally operator independent and quantitative, and artificial intelligence is already producing beautiful results, is already on board of some commercially available instruments. The Bill and Melinda Gates Foundation, funded for $40 million, basically for a projection of use in less affluent areas of the world. But they funded a project for AI for acquisition and analysis and interpretation of AI on smartphone-based ultrasound instruments. And this is the near future, of course. The technology is there. There are some papers already out or soon to be published on this, on major journals. It's so important, so easy, that everyone with a smartphone equipped with a transducer can make the diagnosis of not only B-lines, but because artificial intelligence will help also for more difficult diagnoses that are included in the lung ultrasound spectrum. A second, obviously, as always, the large-scale validation, to have results that are easier to generalize. And we are doing our part with the Stresseco 2030 study. 10,000 patients already enrolled with 50 institutions, from Mayo Clinic to the Sichuan center in China, and 20 laboratories in Italy, 20 different nations across the world. They acquire in the same way B-lines. We have rest and stress information. We are evaluating this data, treated also with artificial intelligence, for the prognostic endpoints that count, all-cause death and other granular endpoints. We need information representing the garden variety of different situations with different technology, different operator, different patients. And this will give the evidence needed for what is already unavoidable from my perspective, that B-lines are there to stay and will accompany clinical work and research studies of our generation, of the current generation of cardiologists, internal medicine doctors, and other specialties. What will change will be the way we acquire and analyze it in a totally automatic and operator independent way. But this future is now.
And the future is bright, as you have rightly said, that we have got the artificial intelligence this day. And also, as the other thing, we notice that the technology has developed so much. The machine is getting smaller, and the image quality is getting better and better. And I found it really interesting. You mentioned that in your experience, that patients themselves are doing their own ultrasound and taking the images. And if the AI can be incorporated into that, the machine can give the result straight away, which is fantastic.
After all, this is what already happens with ECG. They make their diagnosis of atrial fibrillation. They tell you,
yes,
I have atrial fibrillation. What to do? Next step is, okay, I have atrial fibrillation. I take the pill in my pocket.
Yes.
So, this is a simplification, after all, an optimization of the timing, of the cost, and of the complexity of patient care.
Excellent. Thank you. So you have been using this lung ultrasound for a while. What will be your advice to the clinicians they are using it or willing to use in the future in their clinical practice?
Spend one day in a teaching hospital where they have a large experience on this, and in one day they will see everything that they need with a tutoring colleague, or attend one of the many web-based courses, and then to start it in all patients in their everyday practice, because there is no replacement for first-hand experience, as everything that you want to do in medicine, in echocardiography, but probably in life.
Thank you for sharing that golden words. I'm sure my viewers will be encouraged to use the lung ultrasound, at least learn it under supervision, perform it, and then do it independently and get feedback. And that is how we learn. We learn from practice, we learn from mistakes, we learn from experience. You have got
it was a pleasure to meet you, and all the best success to your podcast.
Thank you very much. And it was a really very informative session. I learned quite a lot.